Voy a dar paso ahora a un ponente que es un compañero, es psiquiatra, trabaja en el hospital de Stanford, en Palo Alto, y en el laboratorio del Brain Stimulation Lab, que hasta hace bien poquito estaba en las manos de Nolan Williams, que desafortunadamente falleció hace bien poquito. Y tenemos la suerte de poder atender a el doctor Ala Chambord, que él es el encargado de la parte de la psiquiatría intervencionista en este hospital, especialmente en el área de la hospitalización. ¿Vale? Se encarga de aplicar todo este tipo de técnicas que van desde la estimulación cerebral, la configuración de la estimulación cerebral profunda, TMS y otros tipos de terapia que nos contará. ¿Vale? Y bueno, como hemos comentado antes, va a ser en inglés. Si alguien tiene dudas en algún momento, yo no me importa y podré echar un cambio, ¿vale? Espero que os guste. Okay, Ala, I already introduced you to everyone, so feel free. You can start whenever you want.
Okay, awesome. Well, thank you so much for this warm introduction that I didn't understand much of, but hopefully next year I'll join you in Spain, having learned a little bit more Spanish. But as Vincent kind of said, we're going to be talking about some of the tools of what Jonathan Downer and the late Nolan Williams described as psychiatry 3.0. And we'll talk a little bit about what that means. So we do have a lot of threes in psychiatry. You know, we use tricyclics, psychoanalysis, the id, the ego, and the superego. And when I was thinking about what it is that we do as psychiatrists every day, we all kind of function within these three realms. We are workers, those who use tools to help our patients, whether it's prescribing medications or psychotherapy, or even in diagnosing them, we use tools to assess and clinically identify what it is that they're suffering from. We're also mystics in some ways because sometimes we are using tools that we don't fully know how to explain, but we have some sort of mythical explanation for them. And we're also scientists. We make tools. And a lot of times it doesn't have to come in the form of inventing a whole new thing. It could just be using an augmenting agent that has not been used before with another one. We've all prescribed antipsychotics for sleep or other off label indications, combined medications that perhaps weren't studied together. So these are, we all function within one of these at any one time and sometimes combinations of them. And it doesn't seem that this is very far from even how psychiatry was 9,000 years ago. 9,000 years ago, people believed that whatever mental illness was back then was caused by some supernatural entity, some metaphysical ailment. You looked at or thought of Zeus in the wrong way, and then something bad would happen to you. However, that started to change, and people started to think about things as being more physical. Now, the methods that they used to get at this physical entity were a bit crude, and if you go to any museum around the world, you'll find skulls with holes in them. Was it a step in the right direction? Maybe. Was it the best step forward? Not really. But better than burning them or doing some of the other horrible stuff that we were doing to patients back then. Another 1,000 years later, Galen was very sure of his whole fumigation of the womb thing. Now, again, we're at least focusing on the body. We're understanding that whatever psychiatric illness there is, it has something to do with the entity that is in front of you. Really, the next paradigm shift doesn't happen until the 1800s and the 1900s, and really starts at your neighbors to the north in France at the Salpêtrière Hospital, where really Dr. Pinel changes how we view mental illness, how we describe mental illness, and how we treat it a little bit more humanely. So this is the famous picture where he's unchaining the patients that were at the Salpêtrière. We also have Charcot, who's a product of the Salpêtrière, and of course Sigmund Freud, who is one of Charcot's famous students. And at this time, we're getting really good at being able to describe mental illness, how to put together symptoms together. And in this little excerpt here, Pinellas talks about how schizophrenia as a disorder, the more times you have psychotic episodes, the harder it seems to be to cure. And he describes here as continues in its form and becomes uncurable. And this is the way that we understand schizophrenia now, where it is the only disease within the mental health disorder realm that there is no return to baseline function. Every successive episode, every successive psychotic episode leads the patient a little bit worse off than how they started, regardless of how well you are treating them. They also describe seasonal affective disorder really well. They talk about how as the days get shorter in the winter, a lot of patients do get the blues and they get sadder. And this is a concept that is actually very recently adopted into the DSM, but was described in the 1800s. Now, we were getting really good at describing and sort of putting together symptom clusters, but there was really no treatments around that time. People were using ether, people were using random things, but really no concrete treatments. And this led to something called the therapeutic nihilism era, which then dovetailed into the experimental era. Basically, doctors being like, well, there's nothing that like we can describe all these things, we can define them, but there doesn't seem to be anything actionable that we can do. We don't have any tools to exercise. And this led to a lot of interesting things that some of your neighbors to the west really pioneered. But it really started out with malaria therapy, deep sleep, insulin shock therapy, cortisol therapy, and of course, lobotomies. They won the Nobel Prize for it. Now, was it the best thing that we can do? But it was a step again in the right direction. We understood that the brain was the source of the disease, so therefore it must be the site of the cure. Now, should we take out parts of it? That's probably still debated. Now, while this was going on in Portugal, Spain was having its civil war and inventing foosball. Now, which one was better in the long term for mental health? I think it goes to the Spanish, but we can debate that in the question period. The history of electroconvulsive therapy is actually very rich. It starts out in the early 1900s. And this is the only thing from that era that really survives that we still use today. So that's why it's important to kind of talk about in details. In 1934, we switch over to camphor, kind of stopping using all these other slightly more dangerous ways to induce seizures. And in 1938 was the real paradigm shift. We start using electricity. Using electricity makes ECT repeatable, it makes it tunable, it allows us to change parameters and see whether these different parameters kind of result in different outcomes acutely and in the long run. And in 1951, really the main thing that we still carry on today is the use of succinylcholine. Succinylcholine really changes the patient's experience of ECT. No longer are they sore from these grand mal convulsions that they're having. However, despite this being developed in the 1950s, when they were making the movie One Flew Over the Cuckoo's Nest in 1975, they still depicted the procedure as if it was done in the 1930s. And I hope some of you guys have seen this famous scene where Jack Nicholson is getting ECT, of course, awake, of course, not paralyzed. And this really set the field back many years. And, it doesn't seem to be changing. If you go and watch TV and see any depiction of ECT, it still seems that directors and makers really love that scene. It is dramatic, and our treatments now are rather boring. That's a good thing. But if they're not going to change how they depict our procedures, maybe we should change the name. And change the name not in a reactionary way, but really to a name that better depicts what the procedure is. And there's been a lot of suggestions to change it to neuroversion. In the same way that we use controlled electrical pulses to reset arrhythmias, some would say that ECT is very similar to that. In fact, we actually use less power than a normal cardioversion unit will use to treat arrhythmia. We use about 10 to 70 joules per treatment, especially in the ultra brief technique. And in cardioversion, they use 50 to around 200. And really, the C in electroconvulsive therapy is a bit of a misnomer. As we talked about earlier, we're using succinylcholine. There's really no convulsions that the patient is experiencing. So we've done a little bit of this psychiatry data, how things change from metaphysical to physics. In Psychiatry 1.0, we're doing a little bit more about the content. We're fumigating less. We have a slightly higher understanding of what is going on, at least symptomatologically. And Psychiatry 2.0 is really where some of your teachers existed within, where a lot of us really work within. This is our paradigm. We have better characterizations of diseases based on observable symptoms in the DSM. We understand that neurotransmitters have a significant role to play in the brain, so we understand it more at the synapse level. The monoamine hypothesis, I think a lot of us can debate it, but the fundamental is that we all use psychopharmacology to some degree. And there is some follies to that. Mainly that this was developed in a kind of serendipitous or accidental way. We didn't find a disease and then develop a medication for it. We were usually looking elsewhere for something else, and somehow this related to what we wanted to do. So it starts off really with reserpine, which is a plant extract that was used for hypertensive vascular disease. And when they were testing this in humans and animals, they found that this precipitated depression. Now, when they looked at the action of reserpine, and this is in the 1950s, they found that this depletes brain monoamines by inhibiting the vesicular monoamine transporter. So now we have kind of part one of it. So if there's something that is leading to less monoamines in the brain, it must be the cause of depression. So maybe people who are depressed have less monoamines. The other part, of course, somehow ties to the Nazis. There was large stockpiles of hydrazine after World War II. Nazis were using it to make rocket fuel. This was donated to civilian chemical companies that were trying to figure out what to do with it. So they developed isoniazid, which is an anti-tuberculosis drug. As they were developing it and looking at some of its derivatives, he looked at iproniazid, which in testing, they found that this induced euphoria, psychostimulation, increased appetite, and improved sleep. And so we have these two different explanations for depression, kind of all pointing at the same direction, that there is this monoamine thing at the center of depression. If we bring it up, patients are better. If we suppress it, patients are not doing so well. The problem with kind of going from this serendipitous explanation is that you might not get the full picture. And this is the Stone report that was published in 2018. So the Stone report collects all FDA, all the clinical trials that were submitted to the FDA from 1979 to 2016, includes patients from children to adults. Around 74,000 patients were included in this analysis. And what they found was that compared to placebo, only about 15% of patients had a substantial antidepressant effect. And this was statistically relevant, yes. However, I think the more moot point along all of this is that the differences in the Hamilton D scores. So in all the treatment groups, the average decrease was about 9.8 versus the average decrease in all the placebo groups was about 8.0. So really a difference of 1.8 on a Hamilton D. How clinically relevant is this? I think is up for debate. However, what is not, I think, debated in our field anymore is the futility of really multiple trials of medications. We know from the STAR-D that each successive trial of medication results in slightly worse outcomes and less efficaciousness. And, this is strange in medicine in general. Usually, we discover a disease, we think of a treatment for it, and the hope in the long run is that the deaths or the morbidity from this illness kind of decreases over time. We see this in heart disease, we see this in strokes. But in psychiatry, we're using more and more and more antidepressants than ever before. And yet, our annual suicide rates and the effects of depression continue to climb. So, what are we doing wrong? Again, depression is the leading cause of disability in the world, the second leading cause of mortality. And we have millions of cases, obviously, depending on where you look at. I'm not sure about the statistics in Spain, but things also really took a bad turn right after the coronavirus pandemic. And what we know for sure is that we have patients who do get a response, maybe not remissions from medications, but that about 30 to 40% of patients are treatment resistant. Now, how do we define that? Some people define it as trialing two medications of two different classes with an augmenting agent. Some define it as just one. In children, we define TRD as more than one medication. But regardless of how you slice it, the majority of patients that we see have tried more than five and more than five augmenters and have done psychotherapy and have done other things. So, how do we help these patients? And that's really where Psychiatry 3.0 comes along. There's all these things that are happening around the same time. We also get the invention of fMRI and its wide usage. We get EEG, and we really start using applied neuroscience to come up with new tools for patients. And it really feeds into this understanding that our behavior is a result of electrical and chemical signals, not just at synapses, but really in networks. So we're understanding that all neuropsychiatric diseases is disorders of distributed neural networks. That it's not just Wernicke's area and Broca's area doing one thing. It's a bunch of areas together firing at the same time to induce a mood state of sorts. So, what is interventional psychiatry? You're saying finally he got to it. Interventional psychiatry is a subspecialty within the field of psychiatry focusing on the use of procedures and device-based treatments to manage mental health disorders, particularly in those resistant to conventional therapies, such as medications or psychotherapy. And really, the field aims to integrate neuromodulation methods with targeted pharmacological interventions to provide options for those patients who have not had any response to previous traditional treatments. And we can see that, as time goes on over the last 10 years, the interest in just the term and the Google Trends has significantly increased. So, what are our tools? And these are them by increasing levels of invasiveness. First up is TMS, which I'm sure you guys have been talking a lot about, so we won't go into a lot of details about it. We also have ketamine, whether it's in its racemic form or in its isolated esketamine nasal spray. We talked a little bit about electroconvulsive therapy. We'll talk a little bit about VNS, and we'll talk a little bit about DBS, vagus nerve stimulation and deep brain stimulation. So what is a week of interventional psychiatrists generally look like? I base this a little bit around my schedule. So on Monday, I have a conventional TMS clinic where I see patients, and at the same time, there's a few esketamine patients getting treatments. In the evenings, we also have a 2-hour slot for adults who are maybe working, or recently, we started seeing children above 15 years, so adolescents between the ages of 15 and 18, who are usually at school, and we don't want to take them out of school to just get treatment. So we've opened up a slot during the after school hours for them to come by and do TMS. I'm sure Vincent will talk to you guys a little bit about the history of TMS, but it really starts with Faraday. But the biggest leap really happens with Anthony Barker when he invents this peripheral nerve stimulator funded by the NHS and starts noticing that, well, if I put it over the motor cortex, this stimulates the neurons there and makes people's fingers move. So What else can we do with it? And really, that's where Mark George comes in. Mark George really leads the way for clinical trials in the 1990s. TMS gets FDA approval for depression in 2008, FDA approval in 2013 for migraines. Another paradigm shift happens in 2018 when Jonathan Downers shows that the much shorter 3-minute treatment of intermittent theta burst is non-inferior to the much longer 40-minute treatment of 20 hertz or 10 hertz. 2021 gets another approval for smoking cessation, and I think OCD gets approved somewhere in between then. And then, the next paradigm shift really happens when Nolan Williams really takes the brakes off the car and says, why don't we treat 10 times a day? Clearly, there is a lot of evidence suggesting that more treatments, longer treatments, are having more of an effect, even on patients who have previously failed TMS, and comes up with the same protocol, which is an accelerated TMS protocol that is also neuronavigated. And we'll touch on that a little bit. So the conventional TMS clinic, we generally run 3 to 9 minutes of ITBS for 36 days. We have 2 rooms, 2 machines, 1 or 2 medical assistants at any one day, depending on the volume of patients. We mainly see depression patients, but we also see a lot of treatment-resistant OCD patients. During those hours, we do motor thresholds. We do brief interviews with the patients to talk about how their sleep has been, any changes to their medications, any changes to their mood, any side effects that they've had. There's a lot of things that influence brain excitability, which can change the motor threshold of a patient. If somebody hasn't slept, if they usually sleep 8 hours when they did their MT, for example, and today they slept 4 hours and they also drank 6 coffees, that person's brain excitability is very different than on the first day. So that's why we ask a lot of these questions to make sure that the patient's safe, that they're not experiencing any negative side effects from it. We are also recently starting to do 2 sessions per day. Again, in America, we're very limited about how much freedom we have in exercising some of our tools. So recently, we finally were able to push through an approval to do 2 sessions per day using the conventional methods. And Brainsway also recently got their SWIFT protocol approved, which is their version of an accelerated protocol, where they're doing 6 days of 5 treatments per day, and then followed up by 2 weekly treatments for 4 weeks, up to 8 treatments. And finally, their machines are also able to do intermittent theta burst. So that's kind of what we do on the conventional side. In another building with another machine, we run the Saint service. Now, the Saint service is a kind of specialized service within our field where after the consult and after we've agreed that Saint is the best step for the patient, their next step is to actually go get an fMRI to find a localized target for them. Now, we know from a lot of research, generally where the dorsolateral prefrontal cortex is for most people. However, we do see a lot of variance. And while the magnetic field generated by the machine is not, it's not a laser, but it's also not as big as, for example, the E field generated by the Brainsway machine. The magnetic machine is a little bit smaller. So we try to find this localized target based on where the DLPFC is. And another thing is we look at which group of neurons within the DLPFC is most anti-correlated to the anticingulate gyrus, which is a much deeper structure that has anti-correlation with the DLPFC. So by stimulating the DLPFC, which part of the DLPFC can we stimulate to more strongly inhibit the anticingulate gyrus? After that step is complete and after we get a target, we start treating. And on day 1 to 5, the patients come in at 7:30 and they leave at around 5:30. We do 10 minutes of treatment with 15-minute breaks in between. Now, I talked a little bit about this interventional consult. So what are we doing? We usually schedule a 2-hour visit, which is quite strange in psychiatry and also in America, and nobody's really going to allow you to do that, but they do so at Stanford. At this time, we really look at the patient's treatment history, how their course has been, have they had any periods of euthymia at all. That's usually a very positive indicator that things have gone better before, so maybe it increases the probability of things probably doing right again. What are the indications that they have? What are some of the contraindications that can make maybe some of the treatments that we have not the best option for them? How acutely ill are they? There's a big difference between somebody who is able to come to your clinic, ambulate, and, highly, let's say, highly functionally depressed patient versus a patient who is on the inpatient unit and refusing to eat and not really interacting with the world around them. That patient might not be able to do outpatient, SAINT, or even TMS. So probably ECT is the best option for them. Does the patient have any metal in their head or in their body? Does this make fMRI not possible? Do they have any hardware, maybe near their neck or head? Do they have any plates from a previous accident? Have they had any seizure history? Now, I'm sure you guys will talk about the seizure risk with TMS, but it does seem to be one of those things that maybe we thought of as too big of a risk in the beginning. Really, now we're seeing that unless the patient has had a history of seizures or is on medication that lowers the seizure threshold, it shouldn't be a thing that we find. At least it hasn't been a thing that we found in treating hundreds of patients. Does the patient have substance use history? Does it maybe, this might point us a little bit away from ketamine and more towards TMS. Do they have any medical comorbidities? Do they have any other psychiatric comorbidities? Is it MDD with psychotic features or is it MDD without psychotic features? That might make us think of ECT more versus TMS. Can they tolerate anesthesia? And oddly enough, do they have the time? What time do they have to dedicate to this treatment? Somebody who is retired is a very different time than a single mother who has two children who has to work. She might only have time to come in for a 3-minute session of TMS and might not be able to attend sane service or might not be able to arrange for somebody to pick her up after ECT. So we're also looking practically at what is the best treatment for the patient now. We talked a little bit about ketamine, but ketamine is this, the spirit of interventional psychiatry is really finding things and seeing how they adapt to our field. A lot of things were not invented within psychiatry. So in 1962, ketamine was synthesized as a derivative of PCP while they were trying to develop better anesthetics that can maintain vascular and respiratory tone. It was tested brutally on the jailed population in Michigan. In the 1970s, it was used widely as a field anesthetic during the Vietnam War, again, for this property where it stimulates rather than depresses the circulatory system. And really, there's a big lag phase between then and the 2000s. In the 2000s and the 90s, we start looking at its uses in pain disorders and major depressive disorder. The first placebo-controlled trial in the 2000s shows that it has some rapid antidepressant effects. And in 2006, of course, we have the pivotal NIH study. And then again, a big lag phase until 2019, where it gets FDA approval. And this is mainly because there was not going to be any money to be made from doing all the work that it would take to make ketamine a treatment for depression. You couldn't patent it because it was a racemic mixture that has been widely available and it was very, very cheap. So how do you get around that? You find some people from Yale and you find some people from Johnson and Johnson, and they're like, okay, let's separate this racemic mixture. Let's take only one part of it and also put it in a proprietary way of being delivered. And that's where we get Spravato. What happens from that is that now ketamine seems to be in a very weird place, and I'm really curious to see how this changes over the next few years. Because right now, anybody can get on a Zoom call with supposedly a doctor and order kits of ketamine, whether it be lozenges, gummies, or whatever, delivered to their home, and they can do ketamine therapy. And I don't know, I feel like that's a little bit risky. One of the more interesting things that we're now doing in our research lab is we're doing a study where we're uncaging a nanoparticle encased ketamine using focused ultrasound in specific areas of the brain to see how this can affect pain disorders. Can you mitigate some of the systemic effects of ketamine and maybe some of the addictive properties of ketamine by only releasing it in a specific way using focused ultrasound? We'll talk a little bit about that later. But, and again, thinking back at this interventional consult, what can be some of the things that persuade you this way or this way? What is the type of patient that you might think fits ECT better than TMS? There are no clear definitive guidelines. And again, similar to the way that we describe medications by looking at maybe which side effect profile fits this patient more, we're also looking at maybe some of the indications. So, like I said earlier, is it MDD with psychotic features? If it is, great. And ECT is one of the better options for them. We also find that if they're in the geriatric population, if they're 65 or 70 and above, we also find that ECT to be a little bit more effective. Now, when we start to get to personality disorder and psychiatric comorbidities, that does not seem to be the case. That might be a little bit more on the TMS side, especially if it's also a shorter episode and if the patients are younger. If the patients are younger, TMS seems to be a little bit better for them. And maybe you guys will talk about the Dr. Jonathan Downer's 1D trial. In the 1D trial, where they do 20 sessions in one day, they're using pharmacological agents to augment the TMS, to induce plasticity. So they're using D-cycloserine as well as low-dose amphetamines to boost plasticity within patients to make TMS more potent. Now, younger patients naturally have a higher neuroplasticity. So it's not a big surprise that younger patients tend to respond better to TMS. Now we'll talk about the rest of the week. ECT, we talked a little bit about earlier. After we do our ECT procedures, usually we see about 7 patients. It's a mix of inpatient and outpatient, whether it be for MDD, bipolar disorder, schizophrenia, schizoaffective, catatonia. We also see a few inpatient consults on the medical floors and sometimes the ICU. I would say this maybe happens twice a year, where we either have a status epilepticus case or, as more recently, we had a malignant catatonia case. This is a very interesting case where we had this 24-year-old, he no psychiatric history, started acting bizarre and a little bit psychotic. It was unclear what the picture was. There was thoughts of maybe it was bipolar, but rather quickly things really deteriorated. His vitals were abnormal, and he had to be transferred to the ICU with external cooling. It was on dantrolene, and you know, really when things get really bad is when people really start considering ECT in the ICU. And we did 7 sessions of ECT for him. Around the 4th one, he was able to, breathe on his own. He didn't need the external cooling, and his vitals were slowly returning to normal. On Thursdays and Fridays are kind of dedicated research time. And in this time, we do a lot of the fun stuff. Not super clinically relevant, but hopefully in the future they will be. We have a current study with 2 patients for DBS OCD, where we implanted devices in their brain to stimulate certain areas to alleviate the symptoms of OCD. These were, of course, treatment-resistant patients who have failed medications, have failed TMS, and now this is kind of the only thing that can help them, hopefully. We also have a child TMS treating specific symptoms of autism. So not treating autism, but mainly focused on the drive towards sameness, the repetitiveness that some of the patients with autism have. We also have a study for tinnitus, I know that this is a little bit contentious because there's a lot of research that says TMS actually causes tinnitus. And there's a lot of research that says actually if you stimulate within specific parameters during at certain areas, it would treat tinnitus, or at least change the quality and the tones and the intrusiveness of the tinnitus. So we're looking at that. We have three functional targets that we're working within. We also have a VNS study, the vagus nerve stimulation. Um, in this study, we're not looking at necessarily treatment outcomes. We're not looking at its effect on depressive symptoms. We're really looking at how do different parameter sets influence physiology, immunology, because we know that the vagus nerve has many efferent and efferent connections. It ties to the lungs, ties to our ears and our balance, heart, esophagus. People's voices change when the machine is on, and you'll hear it. If you've ever had that experience, adipose tissue, gut emptying time, kidneys, liver, pancreas. So it's some call it the highway of the body. And yeah, I think earlier on there was a lot of skepticism over VNS because of the time horizon that it really takes for patients to get better. The first trial that they were trying to get FDA approval through was looking at a 6-month time horizon. And when they did the 6-month comparison, there was really no difference between VNS and treatment as usual. And it was really only when they extended that to a year did they get any noticeable differences for patients. Of course, this is a slightly more invasive procedure as it involves short sleeve neurosurgery. You're not really in the brain, but it's still neurosurgeons doing the procedure. There is still an implanted device, and you are still kind of wrapping a coil around the vagus nerve. DBS is probably the most invasive and yet offers us the biggest window into the brain. DBS was really developed for Parkinson's disorder, I think also by the Army, but I'll double check on that later. But what it allows us to do during the procedure is also insert stereo EEG probes. And by during the procedure, we have these stereo EEG probes that are in patient's brain, and the patient is awake. So if we're able to provoke symptoms of OCD, we can see where the hotspot for them is. OCD doesn't have to be this kind of vague disorder. Hopefully, we can identify specific rhythm or signal that we can get from the brain to kind of confirm this and be able to treat it at the site of its origin, much like how we did for seizure disorders. Seizure disorders, before the invention of the EEG by Hans Berger, was very vaguely understood. Some were saying it's possessions, but when we invented EEG, we could say, hey, look, there is the signal that is coming from the brain that identifies what this patient is experiencing as a seizure. And really, that's where I kind of want to leave it at, kind of open it up for questions. But this is our job, and this is kind of what we do between these three different realms of scientist, worker, and mystics. Do we understand precisely how ECT works? No, but we do use it, and we can change some of its parameters to better tailor for patients. If they're having some more cognitive side effects, we can change some of the parameters for it. And really, we're trying to find solutions for the patients who have not had any relief of their symptoms for quite some time, and really offering hope. It's very different for a patient who has tried medications for 20 years to finally even have 3 months of symptom relief, despite the symptoms coming back later. But that will change their perspective on even wanting to engage again with treatments. So I hope that wasn't too long, and I hope there's enough time to have questions.
Thank you, Ala, for your incredible summary of interventional psychiatry and sharing all your knowledge. It was really, really good. So I'm gonna ask them in Spanish if some of them want to ask some question, and I will try to translate if
Yeah.
there's some question. Okay.
And I have
So,
some extra slides at the end about anything specific.
okay.